Orbital cellulitis is defined as an infection of the soft tissues behind the orbital septum, which can be sight and life-threatening. Organisms: adult, Staphylococcus species, Streptococcus species, Bacteroides species. Children: Haemophilus influenza, rare in vaccinated children. Following trauma: gram-negative rods. Dental abscess: mixed, aggressive aerobes and anaerobes. Immunocompromised patients: diabetes, chemotherapy, HIV infection, fungi including those that produce zygomycosis infections, mucor and aspergillus. Causes: paranasal, especially ethmoid sinusitis, preseptal cellulitis, dacryocystitis, midfacial skin or dental infection, and can follow trauma, including any form of ocular surgery. Bloodborne spread from infection elsewhere in the bow. Symptoms: fever, malaise, blurred vision, double vision, reduced ocular motility. Red eye, eyelid and or periorbital swelling, nasal congestion/discharge, sinus headache/pressure/congestion, tooth pain, infra and or supraorbital pain, or hypoesthesia. Signs: inflamed lids, swollen, red, tender, warm, plus or minus chemosis, proptosis, painful restricted eye movements, lygophthalmos, purulent discharge. Decreased periorbital sensation, optic nerve dysfunction, VA, color vision, rapid. Retinal venous congestion, optic disc edema. Workup: ascertainment of tetanus immunization status in cases of trauma. Laboratory studies: complete blood count, blood cultures, gram stain and culture of any drainage, for example, blood and chocolate agars, saber-rod dextrose agar, thioglycolate broth. Lumbar puncture if meningeal or cerebral signs develop. Laboratory studies: CBC with differential and blood cultures. Gram stain and culture of any drainage, for example, blood and chocolate agars, saber-rod dextrose agar, thioglycolate. Imaging: CT/MRI scan of the orbits and paranasal sinuses to confirm the diagnosis and to rule out a retained foreign body, orbital or subperiosteal abscess, paranasal sinus disease, cavernous sinus thrombosis or intracranial extension. Treatment: admit the patient to the hospital and consider consultation with infectious disease, otorhinolaryngology, neurosurgeon for suspected meningitis and oral maxillofacial surgeon for dental infection. Broad-spectrum intravenous antibiotics to cover gram-positive, gram-negative, and anaerobic organisms are recommended for 48 to 72 hours, followed by oral medication for at least 1 week. The specific antibiotic agents vary. Nasal decongestant spray is needed for up to 3 days. Nasal corticosteroid spray may also be added to quicken the resolution of sinusitis. Erythromycin or bacitracin ointment for corneal exposure and chemosis if needed. If the orbit is tight, an optic neuropathy is present, or the IOP is severely elevated, immediate canthotomy or cantholysis may be needed. Use of systemic corticosteroids in the management of orbital cellulitis remains controversial. If systemic corticosteroids are considered, it is probably safest to wait 24 to 48 hours until an adequate intravenous antibiotic load has been given. Surgery: if the orbit is tight, an optic neuropathy is present or the intraocular pressure is severely elevated, immediate canthotomy or cantholysis may be needed. Orbital abscess: consideration should be given to urgent surgical drainage, especially with visual compromise or progression of clinical signs. Thank you.